Good evening, everyone, and welcome to our June installment of Ask the Doctor. My name is Shelley Korean with Skypass Foundation. Lots of familiar names today. I hope everyone is doing well on this fine Tuesday. And for those of you who are new here, Skypass Foundation is a nonprofit based in Dallas, Texas, and we specialize in serving the Parkinson's community. And as a part of that mission, we do these monthly webinar series, interview style, featuring some of the world's leading experts in PD, speaking on a wide array of PD-related topics. And speaking of leading experts, we are honored and excited to have Dr. Joseph Jankovic here with us tonight from the Baylor College of Medicine in Houston. And he will be sharing with us his insights on the pathogenesis and treatment of PD. Before we get started, just a quick bio on Dr. Jankovic. Dr. Jankovic is the recipient of many awards, including the American Academy of Neurology Movement Disorders Research Award and the first National Parkinson Foundation Distinguished Service Award. He has published over 1,200 original articles and over 55 books and has been ranked the #1 expert in the world in movement disorders. After completing his neurology training at Columbia, New York City, he joined the faculty of Baylor in 1977. Dr. Jankovic, I know I speak for all of us when I say that it is an honor and a privilege to have someone with your background and expertise join us today. So thank you for taking the time to be here. We also have Dr. Shilpa Chitnis with us here tonight. Dr. Chitnis is a Skypass Foundation board member, and she's also a professor of neurology and movement disorders expert at UT Southwestern. And she will be interviewing Dr. Jankovic on our topic tonight of pathogenesis and treatment of PD. And with that, Shilpa, we can go ahead and get started.
Okay, well, thank you, Shelley. As always, it's a pleasure. And of course, it's always great to interact with Dr. who I've now known for quite a few years. Okay, so let's just dive into it. So, Dr. Jankovic, I know that there is not one thing that you can pick as a main cause of PD, but if you were to pick, what would be your main focus in terms of causation for Parkinson's disease?
So, you're right. There's not just one thing. Parkinson's disease is probably due to many, many factors. One of the most important factors that contribute to the causation of Parkinson's disease is aging. That's a common theme among all the hypotheses about pathogenesis of Parkinson's disease. But in the last 20, 30 years, we have made tremendous advances in our understanding of the pathogenesis of Parkinson's disease, based largely on discoveries of genes that have been identified as causative genes of Parkinson's disease. But then in addition to these genes, there are other genes that may not necessarily cause Parkinson, but may increase the vulnerability of people to develop Parkinson. So one of the first genes that was discovered as a causation of Parkinson's disease is the alpha-synuclein gene, which was first discovered by Polymeropoulos and his colleagues at NIH in 1966 and 1967 in two critical papers. The first paper found that the gene was on chromosome 4, and the second paper that was published next year in Science discovered that the gene codes for a certain protein called alpha-synuclein. Now, at first, this didn't seem terribly significant, but as people, scientists started to study this alpha-synuclein gene and the protein, the alpha-synuclein protein, it was soon discovered that it's actually a very, very important protein, because the protein was found in the brains of patients with Parkinson's disease, particularly in the part of the brain called Lewy bodies, L-E-W-Y, Lewy bodies. So Lewy bodies is sort of the pathological hallmark of Parkinson's disease. You can't make a diagnosis of Parkinson's disease on the basis of brain autopsy without identifying these Lewy bodies. Even though they have been identified at least 100 years ago, we really don't know exactly what they mean. But with the discovery of this alpha-synuclein protein, it was found that that Lewy body contains this protein, this alpha-synuclein protein. So that was quite intriguing and led to many, many studies on alpha-synuclein. And what has been found over the last 30 years or so is that this protein, alpha-synuclein, for some reason in the brains of patients with Parkinson's disease accumulates, it aggregates, and it causes damage to various parts of the brain, particularly the part of the brain called the substantia nigra, which is the part of the brain that contains dopamine producing neurons. So the leading hypothesis behind the pathogenesis of Parkinson's disease is that this alpha-synuclein, this protein, which is present in all brains of normal individuals, for some reason becomes rogue in people with Parkinson's disease, perhaps as a result of oxidation or some other factors. And it misfolds, it aggregates, and it causes damage to the brains of patients with Parkinson's disease. So that, in a nutshell, is the sort of the current hypothesis behind the pathogenesis of Parkinson's disease and the loss of neurons in the substantia nigra and other parts of the brain that can be affected in Parkinson's disease.
Yeah, no, excellent. This is wonderful. What can you say about the role of environmental toxins like pesticides and insecticides? Where do they figure in all this?
So there is a lot of interest, in the environmental causes of Parkinson, and that's largely based on the discovery of a toxin called MPTP. So MPTP was discovered by Bill Langston in the San Francisco Bay Area among heroin addicts who injected themselves with what they thought was homemade heroin. But it turns out it was this drug or compound or chemical called MPTP. And when they infused themselves with this homemade heroin, which turned out to be MPTP, they developed Parkinson. So scientists then started to study the MPTP and found that the chemical structure is almost identical to paraquat. Paraquat is a herbicide that has been used in the United States, but now it's mainly used in other countries, and has been shown to be a potential environmental toxin that can lead to Parkinson.
Yeah, wonderful. So talking about alpha-synuclein, what do you think is the future of the active and passive immunization against alpha-synuclein? Do you think that these therapies are really going to work out?
So this is a topic that I'm, very interested in for a number of reasons. If we accept the hypothesis that alpha-synuclein aggregates and causes brain damage, then obviously one would want to get rid of this toxic alpha-synuclein. And there have been many strategies that have been investigated and developed to mitigate against this alpha-synuclein and to get rid of it. One of them is to use monoclonal antibody, and I think people in the audience have heard about monoclonal antibodies because of its relationship, to COVID. But these antibodies have been specifically developed to target this aggregated alpha-synuclein, and hopefully it prevents spread of the alpha-synuclein from one nerve cell to another. And we've been very involved in some of the early studies of these monoclonal antibodies and published some data showing that intravenous infusion of this monoclonal antibody once a month may actually reduce the alpha-synuclein in the serum and hopefully in the brain. And as a result of the encouraging study that we published in JAMA Neurology about 2 years ago, another study was subsequently conducted called the Pasadena study, which involved patients in early stages of Parkinson's disease who were infused with this monoclonal antibodies intravenously once a month. And this was a 2-year study, but when we analyzed the data after the first year, we found that first of all, the infusion of this monoclonal antibodies was well tolerated. There were basically no side effects. And then we found that there were some very favorable clinical signals suggesting that those patients who were treated with the monoclonal antibody instead of placebo seemed to have a slower progression of the disease. Now, we chose an endpoint. It's a term that we use in clinical trials that helps us decide whether the drug is effective or not, which consisted of reduction in the MDS-UPDRS. And I think most people in the audience, they know what UPDRS is. It's a rating scale that neurologists use when they are examined in the clinic. And this is one way that we can quantitate the severity of the clinical symptoms. So we decided to use this as sort of the endpoint, and we hypothesized that those patients who were treated with the monoclonal antibody would have a slow progression of their disease as determined by the decline in the score, the MDS-UPDRS, compared to those who were treated with placebo. Unfortunately, we decided to use total UPDRS as opposed to a subset of the UPDRS, and we could not demonstrate that those patients treated with monoclonal antibody had a lower UPDRS than those patients treated with placebo. But then when we analyzed the data more carefully, we found that a certain subset of the UPDRS, so-called motor UPDRS, that focused mainly on some of the motor symptoms of Parkinson's disease, there was a clear separation between those patients who received the active drug, the monoclonal antibody, versus placebo. So that was very, very encouraging. And there were a number of other clinical data points that suggested that the monoclonal antibody might be effective. And as a result, a new study is currently being conducted called the PADOVA study, which is very similar to the Pasadena study that I mentioned, but we changed the endpoint. Instead of using total MDS-UPDRS, we now are looking at the part 3 or the motor UPDRS, and we are quite optimistic that this particular study is going to be positive.
Yes, wonderful. Let me ask you, this. We talked about genetics just a little bit earlier. So when you have a patient that comes to you with new Parkinson's patients, how do you decide in which patients are you going to consider genetic? Do you do genetic testing at all in patients? And if so, what is that population of patients in which you would consider doing genetic testing?
So we don't routinely test all our patients for genetic markers for Parkinson's disease, because even though we think that genetics plays an important role, the actual genes that cause Parkinson are very few. Maybe 10% of all patients with Parkinson's disease have an identifiable gene that causes their disease. So 90% of patients have what be referred to as sporadic Parkinson's disease, idiopathic Parkinson's disease, that is not due to identifiable gene mutation. But if we see a patient, particularly young onset patients who may have started the symptoms in their 30s or 40s, or they have a strong family history of Parkinson's disease, or they are of Ashkenazi Jewish origin, and have a family history, then we test them for some of these genes. So I mentioned Ashkenazi Jewish population, which is a population of Parkinson patients that are more likely to have a genetic underpinning for their Parkinson's disease, often due to a mutation in a gene called LRRK2, or another gene called GBA, glucocerebrosidase deficiency, that causes also Gaucher disease. So those two genes, LRRK2 and GBA, have been found to be major genetic risk factors for patients with Parkinson, particularly of those who are of Ashkenazi Jewish origin. So in those patients, we often test them for those mutations. And I also mentioned juvenile or young onset Parkinson. Those patients have a very high risk for having genetic form of Parkinson, like, for example, Parkin or DJ1 or PINK. These are some of the genes that have been identified as causative genes for young onset Parkinson.
Thank you. And the reason I asked also about genes is, genetic testing is there are therapies, obviously, gene therapy, whether it is LRRK2 inhibitors or GCase modulators that might potentially have a role in treatment. And what would you have to say about that?
So this is a very exciting area of research. We call it precision medicine approach to Parkinson's disease. So I mentioned, for example, LRRK2 gene. This is a gene that codes for a very large protein called dardarin, which means tremor. And this protein, when activated, it can cause damage to the brains of patients with Parkinson's disease through what's called LRRK2 kinase. So this LRRK2 kinase is very active in patients with LRRK2 Parkinson's disease. So therefore, inhibition of the LRRK2 kinase can be beneficial. And there have been a number of studies in animal studies and more recently in human studies that suggest that inhibition of the LRRK2 kinase might have a potential disease-modifying effect, slowing down the progression of the disease. So this is an area of great deal of excitement, not only in patients who have this genetic LRRK2 Parkinson's disease, but possibly also in idiopathic Parkinson's disease without the LRRK2 mutation.
Thank you. And in our current situation with, the COVID and post-COVID era, do you think we are going to see a lot of cases of post-COVID Parkinsonism just on the lines of the 1920, von Economos post-encephalitic Parkinsonism?
So this is obviously a very hot topic during this COVID pandemic. And we just published a paper that just came out last week examining the relationship between COVID and Parkinson's disease. So there have been a number of cases reported where patients developed COVID. Many of them were hospitalized because of the severity of the COVID infection. And then within few days or weeks after that, developed Parkinsonian symptoms. So when we and we had seen a number of these patients in our clinic. So when we carefully examine these patients, those that we have personally evaluated and those that were published in literature, we came to the conclusion that at this point, there is really no direct evidence that COVID causes Parkinson, because these patients that develop Parkinsonism after COVID had markedly abnormal DAT scans. As you know, DAT scan is a way of imaging dopaminergic system. So patients with Parkinson's disease, they have abnormal DAT scan, decreased dopamine production, but this usually takes years for this abnormality to develop. So it would be highly unlikely for these individuals to have an abnormal DAT scan, 2 or 3 days, or maybe a week after COVID, without postulating that the DAT scan was probably abnormal even before COVID, and therefore, they probably had preclinical Parkinson's disease, and it could be that the stress of the COVID, brought out the symptoms of Parkinson, like tremor, slowness of movement, and rigidity and gait and partial abnormalities. So at this point, there's no evidence that COVID causes Parkinson's disease. But what you are referring to is this phenomenon, the von Economo encephalitis that was popularized by the movie Awakening, where people developed influenza, what used to be called Spanish flu, but it probably didn't start in Spain. They recovered from that, and a few months or years later, they developed Parkinsonism, and this is referred to as post-encephalitic Parkinsonism. And when I started my training way back in the late 70s, we used to see still some patients that have post-encephalitic Parkinsonism. You probably hear the noise.
Yes, I heard the thunder there.
Okay, so I'm in Houston right now, and we are under siege by really loud thunder. I hope that's not going to interrupt our broadcast.
Okay, very good. So I want to ask you this question. What is the relationship between smoking and drinking coffee? And do you think these things really do prevent the development of Parkinsonism, if at all?
So again, it's a very interesting question, and patients often ask about it. Should I start drinking coffee? Should I start smoking? Because they read that those two factors seem to be associated with low risk for Parkinson's disease. We still don't fully understand what is the relationship between smoking and coffee, but many epidemiological studies clearly had shown that smokers and coffee drinkers have a lower risk for Parkinson's disease. So there are a number of possible explanations with respect to coffee. We know that coffee contains at least 1,000 different compounds. So it's not just caffeine, but there are many, many compounds, in coffee. And some of those compounds actually have been found quite recently to, for example, prevent this misfolding or aggregation of alpha-synuclein. So that would be one possible explanation why coffee might be neuroprotective or disease modifying and may be associated with low risk of Parkinson's disease. We know that caffeine may have some antioxidant properties, and that may also possibly prevent the synuclein pathology. As far as smoking is concerned, we know that nicotine stimulates the production of dopamine, and perhaps this subclinical release of dopamine in smokers might delay the onset of Parkinson's disease, or actually prevent the development of Parkinson's disease. So there are many hypotheses. We don't have time to discuss all the hypotheses, but clearly coffee and smoking is associated with reduced risk for Parkinson's disease, but it does not mean that patients with Parkinson's disease should start smoking or start drinking coffee.
They can drink coffee.
Right.
So what can you tell us about the role of regular exercise in slowing down the progression of Parkinson's disease? Because I can say now safely, over 20 years of being a Parkinson's doctor, I have some patients who are exercise fiends. I mean, they exercise, and I look at their UPDRS, the part 3 UPDRS from the time that I started with them and now, and they are doing so much better compared to people that do not exercise regularly.
Well, I mean, it's obviously a very important observation that's based on your own experience, but that observation is supported by many, 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 many studies, both animal studies and human studies. Right. And patients often ask me, is there anything I can do to slow down or prevent the progression of the disease? And I always say, of all the things you can do, exercise is by far the most important. So there have been many studies, including in animals, that have shown that exercise could be potentially neuroprotective. Animals who are forced to exercise have a release of certain trophic factors, like BDNF, for example. These proteins or trophic factors may nurture the neurons and protect them from damage. So that is one mechanism by which exercise may be neuroprotective. There are many other possibilities, but there's no doubt that Parkinson patients who exercise have a slower progression of their disease than those who don't exercise. And by exercise, I don't mean just taking a little stroll around the block. A lot of patients think that that's exercise. That's not exercise. We talk about high intensity exercise. The patients really should be huffing and puffing when they exercise, providing that their primary care physicians or cardiologists, allows it. Obviously, Parkinson's patients who have cardiac disease should consult with their doctors before they get on this, vigorous exercise program. But the vast majority of patients with Parkinson can engage in this exercise program, and it has, many benefits beyond what I just mentioned about the neuroplasticity and improving and increasing the BDNF or other trophic factors, but also in terms of their general condition, improving their strength. Parkinson patients who lose their strength do very poorly. And, as they say, if you don't use it, you lose it. And that is so true, for Parkinson's patients, just like, for other people. So I strongly encourage all my patients to get involved in vigorous exercise program.
Yes, very much so. In fact, I told a patient today that, we're going to have an appointment in 3 months, and I want to see you exercising 5 days a week. And I was joking, but I said, if you haven't reached that goal in 3 months, just cancel the appointment and only make an appointment when you reach that goal. But you're right, it's so important to exercise. So the holy grail, of Parkinson's disease, a neuroprotective agent. Do you think in our lifetime we're ever going to see a neuroprotective agent?
Well, again, it's a timely question, especially in view of the recent FDA approval of the drug against Alzheimer's disease. Just today, I was interviewed by the scientific journal called Nature. They asked me what I thought about the FDA approval for this Alzheimer's drug. And I must say I was very critical of the approval because it was based on change in the amyloid in the brains of patients with Alzheimer's, but not based on any kind of clinical benefit. So I thought that this decision by FDA to approve the drug was misguided, and many of our colleagues, as you know, actually resigned from the advisory panel in protest against that decision. So you have to excuse that noise. It's in the background. We have loud thunder here. So on one hand, I was critical of the FDA's decision. On the other hand, I can see why they derived at a decision being under so much pressure from the Alzheimer advocacy groups trying to have a drug that potentially can slow down the progression of the Alzheimer. Having said that, I'm actually encouraged by what is going on in Parkinson's disease. I mentioned this monoclonal antibody study that we are currently conducting at Baylor and other centers that is quite promising. But there are other drugs. There are vaccines against alpha-synuclein. They are being investigated. We talked about LRRK2 kinase inhibitors, not just for patients with LRRK2 genetic disease, but also for idiopathic Parkinson's disease. And there are a number of other disease-modifying therapies that are currently being investigated. So I think the pipeline is quite healthy. I hope it will result in discovery of a truly disease-modifying drug that eventually will be approved by the FDA. The biggest problem with these studies, not only because they have to be long-term studies to show the benefit, but also because we don't have a test or biomarker for progression of Parkinson's disease. In Alzheimer's, they use this PET scan to image amyloid, but unfortunately, we cannot image alpha-synuclein. That millions and millions of dollars have been spent on research, hopefully leading to imaging technique that would allow us to view alpha-synuclein by either PET scan or MRI scans. But so far, we have not found any kind of technique. So we have to rely on the clinical rating scales like the MDS-UPDRS as a biomarker for the progression of the disease.
Yes, thank you. So I'm going to switch gears a little bit, and I'm going to talk about early Parkinson's disease. So firstly, you know, how do you make a diagnosis? For the patients always want to know, how do you make a diagnosis of Parkinson's disease when you see a patient in clinic?
Well, again, we don't have a diagnostic test for Parkinson's disease. We cannot draw a blood and it comes back, positive for Parkinson's disease. I did mention the DAD scan, which is sometimes helpful in confirming the diagnosis. But basically, the diagnosis is based on clinical criteria. The patients, really should have the 4 cardinal signs of Parkinson, at least most of them, including rest tremor, slowness of movement, so-called bradykinesia, rigidity, gait and partial instability. Those are the 4 cardinal signs that are frequently used in making a diagnosis of Parkinson's disease. But we have to be mindful of the fact that just because the patient has these Parkinsonian signs, it doesn't mean that they have Parkinson's disease. There are many Parkinsonian disorders besides Parkinson's disease. So even though Parkinson's disease accounts for like 70% of all Parkinsonian conditions, 30% of Parkinsonian symptoms of patients who have these Parkinsonian symptoms and signs have other diseases besides Parkinson's disease. So we always look for some atypical features that would lead us to the correct diagnosis. For example, if the patient has early falls and is unable to look down, on our examination, they may have a condition called progressive supranuclear palsy or PSP. If they have a lot of autonomic symptoms such as low blood pressure on standing, bladder problems, these are features that suggest that they may have a condition called MSA or multiple system atrophy. So these are just examples of patients who may have the Parkinsonian symptoms, but do not have Parkinson's disease, but instead have what is referred to as atypical Parkinsonism. There's virtually dozens, if not hundreds, of these conditions that can cause Parkinsonism. Can you hear me?
Yes.
The thunder is really loud.
Is it raining?
It's raining, of course, yes.
Okay, so let's say you diagnose a person with early Parkinson's disease. They're very mildly symptomatic. They probably don't have that much of an interference into their day-to-day activities. What is your approach to treatment? Do you say go away and come back when you have more difficulty with your ADLs, the activities of daily living, or do you basically say that now that you're confident that this appears to be Parkinson's disease, do you consider treating them? And if so, what agents are your first line for these patients? So two-pronged questions.
Well, I never tell my patients to go away. That's one thing I never do. I try to be as welcoming to the patients as possible, and really spend some time with them, especially during the initial visit, to help them understand, what are the symptoms that they have, what are symptoms of Parkinson's disease or some other Parkinsonian disorder that we just talked about. If the symptoms are troublesome for the patient and they interfere with their functioning, then I often actually start a patient on levodopa. Levodopa, as you know, is the most effective treatment of Parkinson's symptoms. But for a long time, at least the last 30, 40 years, many Parkinsonologists, neurologists who specialize in Parkinson, would delay the onset of levodopa therapy, which has resulted in what's often referred to as levodopa phobia. So there are patients who have read about the possible toxic effects of levodopa, and they have been disproven. There's really no evidence that levodopa somehow accelerates Parkinson's disease or is damaging to the brain of patients with Parkinson's disease. But nevertheless, for a long time, there was this theory and practice among Parkinsonologists to delay levodopa therapy and initiate therapy with other medications like monoamine oxidase inhibitor, like rasagiline or selagiline, or use dopamine agonists like pramipexole or ropinirole and other dopamine agonists. But these drugs have their own problems, their side effects. So when a patient is troubled by the symptoms, then I usually go ahead and start the patients on levodopa, since that is the most effective treatment for their symptoms.
Yes, absolutely. Do you think that the MAO-B inhibitors, selegiline and especially rosagilin, in light of the Adagio trial, do you think that if the trial had been done with only 1 milligram and not the 2 milligram dose, do you think we would have gotten a neuroprotective indication? And do you really think that it is neuroprotective?
So, you are referring to the trial called Adagio Trial that we participated in. It was a very interesting design where it's called so-called delayed start design. And what that means is that one group of patients started on rasagiline, this MAO-B inhibitor, early, and another group of patients started 6 months later. So we delayed the onset of rasagiline therapy. And the hypothesis was that those patients who started early on rasagiline, if rasagiline had neuroprotective effect, would have a slower progression of the disease. And that indeed was demonstrated at the end of the study. So those patients who were treated with 1 milligram of rasagiline clearly had a slower progression of their disease than those patients who were treated with placebo. The problem is that there was another part of the study where instead of using 1 milligram, we used 2 milligram of rasagiline. And for reasons that are still very difficult to explain, that study did not prove that rasagiline slows down progression of the disease. So we have this paradoxical observation where 2 milligram dose was less effective than 1 milligram dose. And frankly, because of this paradoxical result, FDA rejected our application for rasagiline as a disease-modifying therapy.
Yes, very, very true. So my question is, you did mention dopamine agonists, but today, like knowing all that we know about the long-term side effects associated with dopamine agonists, is there a role for them still in therapy in younger patients, especially given that younger patients may be at a higher risk of developing some of the complications such as impulse control disorders?
So just, so we understand what we mean by dopamine agonists. These are drugs that don't replace dopamine, but stimulate the dopamine receptors directly. And I mentioned some examples: pramipexole, ropinirole, and Nupro, rotigotine. These are drugs that clearly have been shown to be effective. And there were early studies that showed that patients who were initially treated with these dopamine agonists before they were starting levodopa, later on had actually lower risk of motor fluctuations and dyskinesias, the two most common side effects of levodopa therapy. So that was encouraging. And because of these studies, and there have been many of these studies that clearly showed that the early use of dopamine agonist delayed or prevented levodopa-induced fluctuation, dyskinesia, led to this practice of using dopamine agonists early before levodopa. But what was found later on that if you examine these patients like 5 or 6 years later, you find that there is really no difference whether they were early treated with dopamine agonists or not. They have had the same risk of motor fluctuation, dyskinesia. On top of that, since the introduction of dopamine agonists, we have found that these drugs have been associated with a variety of side effects, the most important of which is the impulse control disorder, ICD, where patients have impulsive behavior. They may develop hypersexuality, compulsive shopping, and hobbyism, and a number of other symptoms that we associate with ICD. And in addition to ankle swelling and a number of other potential side effects. So dopamine agonists are rarely used today. I think most patients are treated, with levodopa if they have troublesome symptoms.
Yeah, absolutely. So, as far as the use of levodopa is concerned, when you start with a formulation, is there any logic that you use whether you're going to decide if you're going to use, the IR cinemat or the CR cinemat or Stalevo or, the latest, the relatively new kid on the block, Rytary? Like, do you have a preference on which one you use, or is it individual patient based?
So most of the patients are started on what you refer to as IR, immediate release levodopa or cinnamon. Cinnamon is a combination of levodopa and carbidopa. Now, you mentioned CR cinnamon, which is a control release cinnamon. I rarely ever use that formulation for a number of reasons, because studies have shown that patients who are treated with CR cinnamon have less predictable response to levodopa, and there's really no strong evidence that it actually has a longer duration effect than the IR cinnamon, maybe slightly longer. But because of the unpredictable absorption, I rarely ever use cinnamon CR. I may sometimes use it as a nighttime formulation in patients who frequently have to go to the bathroom in the middle of the night. So they take the CR cinnamon, either 5200 or 25100 CR, to sort of help them function, at night. Rytary is another formulation of levodopa that has a longer duration of benefit. The problem with Rytary is it's very expensive. Many insurance companies do not cover it unless you can show that the patients did not adequately respond to the cinnamon or the IR levodopa. But in some patients have motor fluctuations and short duration of benefit from each dose of levodopa, then using Rytary might be beneficial. So I do have a number of patients taking Rytary for that reason.
Yes, absolutely. I mean, that is actually, interestingly enough, a pharmacy. It's Walgreens in Houston that actually has subsidized Rytary, and we've been sending our prescriptions there, and the copay is now for the patients. So it's basically very, very low, so to say. Dr. Jankovic, I'm going to ask you one last question, and then I'm going to go to the patients. So David, Dr. Charles at Vanderbilt has for the longest time been trying to do early DBS, like very early, not early DBS as the study from that came out of the Netherlands, but more so not early STIM, but really patients with stage 1 or 2 Parkinson's that do not have any motor fluctuations, do not have any dyskinesias, and he really is trying to consider DBS in those people. And do you think that early DBS is there a neuroprotective role? And do you think that would that prevent dyskinesias and motor fluctuations from happening once patients are treated long term with levodopa?
So this is a very controversial issue, and we could spend hours discussing this particular topic. But traditionally, deep brain stimulation has been used in patients who have severe motor fluctuations and dyskinesias that cannot be adequately treated with pharmacologic therapy. And that group of patients still represents like 90% of all our patients with DBS. What you are referring to is some of the studies championed by David Charles and others, suggesting that perhaps patients with earlier stages of Parkinson's disease who have mild motor fluctuations, or who are who even are in early stages before they develop motor fluctuations, might possibly benefit from DBS. The data that Dr. Charles presented is encouraging, but I don't think that has been adopted into general practice. And I don't think that many Parkinsonologists now advise patients to have DPS when they are in relatively early stages of Parkinson's disease.
Yeah. Oh, and before I go to the patient questions, I have one last one. So, is there a role for gene editing, the CRISPR technique, in genetic forms of Parkinsonism, as they're trying to use for, some other disorders?
Not yet. That's the short answer. That's being discussed, particularly with reference to some of the monogenetic forms of Parkinson, like LRRK2 or GPA. But it's way, way too early to suggest that CRISPR might be helpful in as a treatment for these patients.
Okay, thank you. That was very, very excellent, Dr. Jankovic. Such clarity of understanding for all of these questions. And I'm going to try to read some questions here from patients. Let me go. So, with a paternal grandfather and a maternal grandmother with PD, how likely would grandchildren get PD?
Well, one way to answer the question is to actually do the genetic testing and check for these genes that I mentioned. Some of these genes are inherited in what is referred to as autosomal dominant pattern, like for example LRRK2, where each offspring has a 50% chance of inheriting the gene. But just because they inherit the gene, it doesn't mean that they get Parkinson. There's such a thing called penetrance. It's an important concept to remember. So just because somebody has the gene mutation, it doesn't mean that they will develop Parkinson. Only 1/3 of patients who have the gene mutation actually develop Parkinson because of the low penetrance of this particular gene. But nevertheless, in an autosomal dominant disease like LRRK2 mutation, each offspring has a 50% chance of inheriting the mutation. In the other diseases like PINK1 or Parkin or DJ1, these are inherited in an autosomal recessive pattern, so that it tends to skip the generation because each offspring has less than 25% chance or 25% chance of inheriting the gene. So in an example where in a family there's a skipping of generation, that often suggests autosomal recessive inheritance, and one could search for these genes like Parkin, PINK1, and DJ1. So genetic testing might be useful, and there are a number of commercial companies that do genetic testing. If all the genetic tests come back negative, but you still suspect a genetic form of Parkinson, you might consider what's referred to as whole exome sequencing, which is a genetic technique that would identify genes that may not be identifiable by these commercially available tests.
Could a skin biopsy diagnose Lewy body dementia?
Well, so skin biopsy is increasingly used as a potential marker looking for Lewy body pathology that I mentioned earlier. So we talked about Lewy bodies present in the brain, but Lewy body type pathology, what's called Lewy neurites, can be present also in the skin, and that has been demonstrated by a number of studies. These biopsies, skin biopsies, do not necessarily make a diagnosis of Lewy body dementia. They just suggest the possibility of Lewy body pathology, like some of the alpha-synuclein abnormalities that we mentioned in Parkinson's disease, multiple system atrophy, for example, and dementia with Lewy bodies. Those are examples of synuclein pathologies that can be identified by skin biopsy. The test has not yet been approved commercially, and it's not as reliable as some other tests, like, for example, DAT scan would be more predictable of dopaminergic deficit.
Absolutely. And just to tag on to that, uh, the Campbells want to know, when is CAT scan administered? Can it differentiate between symptoms associated with PD?
So DAT scan, when it's abnormal, just suggests that there's a dopaminergic deficit. It doesn't tell you why. It's most commonly seen in Parkinson's disease, but it's also seen in MSA that I mentioned, progressive supranuclear palsy, or PSP. It's present in many other Parkinson disorders besides Parkinson's disease. The most frequently used for DAT scan is to differentiate between Parkinson's disease and essential tremor. Essential tremor is a genetic neurologic disorder that presents with tremor, and sometimes clinicians, including experienced Parkinsonologists, have trouble differentiating between essential tremor and Parkinson's disease. And in some cases, both conditions can coexist. So DAT scan sometimes is helpful in differentiating between Parkinson's disease and essential tremor.
How does one become a candidate for the monoclonal antibodies? Is there any evidence that it slows down cognitive change?
So monoclonal antibodies are currently tested in research clinical trials. You cannot have access to monoclonal antibodies unless you are a participant in one of these clinical trials. So far, there's no evidence that monoclonal antibody cause dementia or any cognitive deficit. So far, the data suggests that it's a safe treatment.
Thank you. My father had PD. One son had seizures. The other has social anxiety disorder. Is there any genetic link possible here?
So there's no genetic link between Parkinson's disease and epilepsy or seizures. Many patients with Parkinson's disease, of course, have anxiety, particularly during the wearing off symptoms. But it doesn't necessarily mean that the anxiety is genetically related to anxiety that is seen in people who don't have Parkinson's disease.
What are your thoughts on the possibility of low intensity light therapy having a role in promoting neuroplasticity?
So light therapy has been sort of popularized recently by a number of centers. The data, I think, is at this point inconclusive. I'm not convinced by any data to suggest that light therapy might be useful in Parkinson's disease. It's a short answer, but I can give you a longer answer if we have time.
Thank you. What are the requirements for participating in the study that Dr. Jankovic talked about early in the presentation for the monthly injections, the study that followed the Pasadena study?
Well, I mean, the patients need to consult with their neurologist to see, which centers might be enrolling, and they can be referred to those centers. So the study is supported by Roche, and I suspect that on the website of Roche, there is probably a list of centers that participate in this Padova study. The Pasadena study is closed, but Padova study still, I think, is enrolling.
Going. Okay, thank you. There have been studies that indicate that the reduction in cognitive ability in patients following DBS. What have you observed?
Reduction in what?
Cognitive ability.
Again, there's really not that much evidence that DBS interferes with cognitive function. There have been many studies to suggest that cognition is relatively spared in patients who undergo either STN or GPI DBS.
Can you repeat regarding MSA and incontinence?
MSA and what?
Incontinence?
So MSA, the multiple system atrophy, is the Parkinson's disorder that is associated with these autonomic symptoms that I mentioned, like low blood pressure on standing, erectile dysfunction, incontinence, constipation. Those are some of the autonomic symptoms that are characteristically present in MSA, although they can also be present in Parkinson's disease. But in Parkinson's disease, they tend to occur in later stages of the disease, whereas in MSA, these can be the presenting symptom. Like, for example, erectile dysfunction may precede the onset of any kind of motor symptom like slowness of movement by 5-10 years or even longer.
What causes Parkinson's? What causes PD dementia in a PD patient?
So 25-30%, maybe even higher percentage of patients with Parkinson's disease eventually do develop cognitive deficit or dementia. When one examines brains of patients who have Parkinson's disease and dementia, one often sees a number of factors that contribute to the dementia, not just the Parkinson's disease. So there could be dementia associated specifically with Parkinson's disease, but many, if not most patients who have Parkinson's disease and dementia turn out to have coexistent Alzheimer's disease on autopsy or some other cause of dementia. So Alzheimer's disease, as you know, is very common. It's at least 4 times more common than Parkinson's disease. So it's not uncommon for people to have both Parkinson's disease and Alzheimer's disease.
And I think, Shelley, that's pretty much all the, if anybody has any other questions, that's pretty much all the questions we have. We're doing excellent for time with 7:59 p.m. And
So there was one more question that I put in your private chat, if you can just check that quickly. It came in with registration.
Which one is that? How can I support clinical trials? Is that 11?
Mm-hmm.
How can I support clinical trials involving targeted delivery of corrective RNA to the substantia nigra?
Well, I'm not aware of any clinical trials right now that somehow would target RNA into substantia nigra. I'm not exactly sure what the person is referring to, but to my knowledge, there are no trials currently underway using RNA, to target substantia nigra. So, I would suggest you discuss it with your neurologist to find out what is really available in this arena of experimental therapeutics.
And Shelley, I have one last question. So, Dr. Jankovic, what are your views on nilotinib?
Nilotinib?
Nilotinib, yeah.
Yeah. Well, I mean, the studies that were done with that particular compound were negative, so I don't think we're going to hear much about it. So I don't think we need to spend more time on it.
Okay, Shelley, over to you.
Right. This was great. Thank you so much, Dr. Jankovic, for your time. And thank you always, as always, Dr. Chitnis, for conducting this interview. We got a ton of questions, lots of interaction. I think that's an indication of how much our attendees enjoyed this session. This session is being recorded. So if you have a loved one or a friend or just a family member, perhaps, that you think can benefit from this information, I will be sending out the YouTube link to this webinar. So please feel free to pass this along to them. And one last thing, Dr. Jankovic had referenced atypical Parkinsonian disorders in this conversation, and that is actually the topic of our next Ask the Doctor webinar on July 19th. So if that's something that you're interested in, perhaps if you have more questions on that topic, registration is now open at skypassfoundation.org. I just put the link there in the chat. So feel free to head on over to our website before you shut down your computers for tonight and register for that on July 19th with Dr. Irene Litvan. And if you have any questions on that, you can always reach out to me. Thank you again, Drs. Chitnis and Jankovic. Thank you everyone for joining. We'll wrap it up. Have a great night.